Hi, everybody. I'm Jim Stringham. I'm the Chief Scientific Officer for MacuHealth, and today we have the privilege of spending some time with Dr. Jerry Sabag, a world-renowned specialist in diseases and therapies of the vitreous, macula, and retina. He was educated at Columbia and Harvard and is the founding director of the VMR Institute for Vitreous, Macula, and Retina in Huntington Beach, California. Dr. Sabag is also a senior research scientist at the Doheny Eye Institute in Pasadena and full professor of clinical ophthalmology at UCLA. Dr. Sabag has authored hundreds of publications and has lectured throughout the world, sharing his knowledge about the eye. He's received numerous awards from many prestigious institutions, and today we have the special opportunity to learn more about him and his work. Indeed, it's a privilege, Dr. Sabag. I appreciate you joining us today.
Thank you very much. Kind invitation.
Yeah. So I'm curious about how you got started as an eye doctor and what led to your interest in the vitreous and its impact on ocular health, patient well-being. Can you recount that progression for us?
It's an interesting story. When I was in medical school at Columbia, I was more interested in the surgical disciplines than the medical disciplines. And so I looked at each of the surgical subspecialties. I spoke to people who were training and who were already professors in those domains. I went through a process of elimination. I ended up with ophthalmology, which I discovered was much more than a surgical subspecialty because, in fact, the majority of eye diseases that we treat are treated medically and not surgically. So that was quite a boon. And I also learned that, in contrast to other medical specialties, ophthalmology has a wide range of patients, men, women, young, old, and it makes it less confined than some of the other medical specialties. The third major benefit of having chosen ophthalmology was how readily the field adapts new technology, both diagnostic technology, but also therapeutic technology, in contrast to some other medical specialties which are slower to adopt new technologies. So the combination of those three elements led to my career in ophthalmology that I have enjoyed immensely. Specific interest in vitreous arose when I made the decision to go into ophthalmology and was advised by the dean of students at Columbia to spend the entirety of my 4 months of elective time during my senior year in medical school doing research because ophthalmology is very competitive. And it was her opinion that doing work in a laboratory dedicated to the eye would give me an advantage in securing a position in a residency in ophthalmology. And so I met with a few of the people in the Department of Ophthalmology at Columbia and ended up working with Andre Balash, who is renowned for a number of things that he introduced and developed in the field of vitreous, but also in ophthalmology in general. He was the main force behind the development of Helon, which is an agent that's used in cataract surgeries all over the world. But he introduced me to vitreous. He was the first person in the world who ever said the word vitreous to me. And I knew nothing about it, and he knew a lot about it, and assigned me a couple of projects to research the anatomy of the vitreous body in humans. He had access to very large numbers of autopsy eyes through the New York Eye Bank for sight restoration. And so there was a steady stream of eyes that people had donated post mortem that I was able to dissect and study and develop a fascination for this very enigmatic and mysterious structure. It's really amazing how the largest structure within the eye is the least understood of all of the different parts of the eye. So it has provided me with a lifelong fascination, and I've really enjoyed very much all of the work that I was able to do in different laboratories with different collaborators all over the world. most recently, the past couple of decades, with a steady stream of students from both USC and UCLA. And so it's been a wonderful undertaking that I've enjoyed thoroughly, and even at this old age, seem continuing to be fascinated by it.
You're not that old. I know this. Certainly mentally as sharp as ever, and that's what's really important, right? Yeah, it is fascinating that the vitreous is, even by most accounts from eye doctors, is this sort of, well, it's a space that light passes through. It's you have anterior, and then you just got to get it to the retina. But yeah, you're famous in the vitreoretinal world for the phrase "look at the vitreous, not through it." Can you elaborate on this point a little further to kind of underscore what you mean by that?
Sure. Well, a moment ago, you touched upon it using the word space, that people consider vitreous a space or a cavity. In point of fact, it's not. It's an organ, just like any other organ in the body. It's just that it's 98% water and it's designed, quote unquote, to be transparent. So the maximum number of photons can pass through unhindered, attain the retina for photoreception to occur and for true vision to begin. The proclivity that most people have to not consider vitreous an organ or a tissue, but to consider it a space, stems from a lack of understanding. And it's understandable that it's not well understood because it's 98% water. So how could that be important? Well, it's the 2% macromolecules that reside within the vitreous body that make all the difference in the world. So my attempts to understand how vitreous is composed and to learn how it changes throughout life during aging, how it's influenced by conditions such as myopia and diabetes and other situations, um, that has resulted in my looking at vitreous as opposed to just looking through it. And so perhaps it's a bit trite to put it that way, but I think that it does encapsulate the essence of what I've tried to do is raise people's awareness as to the importance of vitreous in both health and in disease. And so I've encouraged people to look at it, to study it, to learn more about it, as opposed to just look through it, which we do every day in both of our eyes.
Yeah, absolutely. I mean, I think it's perhaps trite, but an incredibly important point, and a point that's really you've dug into in research. You've been heavily involved in research throughout your career. You're an exemplary clinician researcher in my estimation. With regard to vitreous floaters and patient outcomes and quality of life, can you tell us some of the key findings from your scientific work?
Well, it began when I actually listened to my own advice. As I just described, I've been encouraging people to look at vitreous, not just through it, to try to understand it, to try to learn more about it. And the realization dawned upon me about 15, 16 years ago that the way we handle patients complaining of floaters is is really not appropriate. And it too stems from a lack of understanding of the origin of the floaters. And I was just like everybody else for 20 years. When a patient presented with floaters, I checked their retina, made sure there were no holes or tears or detachments, hemorrhages and the like. And in the absence of any pathology of the retina, I told the patient, no, you're fine. There's no problem. And that's the typical approach that most clinicians take. But it turned out to be a very frustrating experience for many, many patients because here they were complaining about something and we checked to make sure there were no diseases of the retina, but failed to address their problem, failed to understand that these, for the most part, are people who have much better things to do than waste their time and time sitting in my office complaining about something unless it weren't something that really bothered them. And our tendency to dismiss it was almost bordering on offensive because it was basically telling the patient, no, you don't have a problem. Well, that's a problem as we understand it or as we don't understand it. But as far as the patient is concerned, they do have a problem. And it was a very frustrating experience for patients throughout the world. And I hear this again and again and again. And so I stopped talking to patients and I started listening to patients, which is actually a very um, strong tenet in medicine in general, something that I learned when I was very young. I spent 2 years at the Karolinska Hospital in Stockholm studying and developing application of computers to medical decision making. And my professor, who was an old-time cardiologist, but with an eye to the future, kept saying to me and other students, listen to the patient. They're telling you the diagnosis. You just have to listen to the patient the right way and it'll help. Don't just order tests of blood and scans and the like, but listen to the patient because they're telling you the diagnosis if you listen to them the right way. So I started listening to the patients and I started trying to figure out ways to better understand why they are unhappy with their vision, what was going on inside their eyes. And as soon as I began to do that, it led to the development of two very important tests that we perform on a regular basis to better understand what's going on in the vitreous body. The first is an evaluation of vitreous structure. We developed quantitative ultrasonography to evaluate vitreous structure. Ultrasound has been around for a very long time, and it's been very helpful in the management of a variety of eye diseases. But it was kind of shoved off to the side when OCT, optical coherence tomography, was developed because it generated views of the retina that we never had before. And it's been very helpful to evaluate the retina, but it hasn't been very helpful to evaluate vitreous. And it led to people paying more attention to the OCT findings as opposed to using the ultrasound to evaluate vitreous. So we dusted the ultrasound machine off, pulled it out of the closet, and started using it and started working with some very brilliant acoustic engineers in New York to develop a way to not just image the vitreous body with ultrasound, but also to measure what's going on inside the vitreous body with quantitative ultrasonography. So that gave us a number that we could utilize to characterize changes within the vitreous body, specifically the density as measured by ultrasound, so-called echo-density, and be able to assess the severity of the structural changes within the vitreous body as mild, moderate, severe, but actually have numbers. The other major innovation was, again, something that has been done by others everywhere for a very long time, and that's to measure contrast sensitivity. Contrast sensitivity is the ability to discern between shades of gray. And there are a variety of tests that can be employed and have been employed for many years, but never in this setting. And so we began to measure contrast sensitivity in patients complaining of floaters and found that there was wide variability, ranging from very minimal abnormalities to very significant abnormalities. And in point of fact, in a series of 195 consecutive cases, we found that the average degradation in contrast sensitivity in patients who chose to undergo surgery for their floaters was 91%. Every one of those patients had normal visual acuity being the ability to see small letters on the eye chart. That's normal. So that's not a very useful test in evaluating patients who have floaters. But contrast sensitivity measurements turn out to be very useful in evaluating patients complaining of floaters to determine the impact that this has on their vision. So, armed with a structural assessment and a functional assessment, we are able to approach patients much more scientifically and much more objectively. It has really made the management of floater patients much easier because in the past, before we started doing all of this, It basically came down to a personality test. Do you believe this individual is truly afflicted with floaters, or are they just overreacting to something that we all experience? There was no way to tell the difference between those two. But with quantitative ultrasonography and by measuring contrast sensitivity, we have objective metrics of the severity of the condition with which to discuss the situation with the patient. And it's done two things. It's certainly made it much easier to tell a patient, yes, you have a problem. I have measured that problem. Here are the results of those measurements, and here are your options for therapy. So it was much easier to say, yes, we can do something. But it also made the converse easier, meaning in the old days, a patient who had floaters who, for one reason or another, didn't seem that severe, were told, no, you don't really have a problem, they would take offense to that because it was basically saying, no, I don't believe you. And there was no basis for that statement. But armed with quantitative ultrasonography and measuring contrast sensitivity, I'm able to say to somebody, listen, compared to hundreds of other people who we've measured over the years, your situation is mild. It's not that bad. And I've had this experience multiple times where initially patients are very disappointed when I say that because they came hoping for a cure, hoping to be rid of this bothersome situation. And here I'm telling them their case is not severe, it's not in need of any intervention. And after that disappointment phase passes, they seem to find solace in the fact that these were objective measurements made scientifically, and we have a very large database with which to compare this individual's results to hundreds of other people and tell them, no, you're not really that bad off. That ended up being a source of some satisfaction, a source of some comfort that, okay, I guess, compared to hundreds of other people, I'm not that bad off. So maybe I can try to cope or find other non-invasive ways to manage this problem. And it turned out to be a godsend. It was so much easier, it has been so much easier to manage patients and to at the very least, give them more information than they've ever received before. The ultrasound is very useful because in a situation where a patient is evaluated complaining of floaters, but no ultrasound is done, there's a disconnect between the condition and the testing and the patient and the doctor. But with the ultrasound, you can show on the screen, this is the source of the shadows that you see as floaters. And patients find that to be a revelation. Oh my God, I've never been shown why I have floaters before. So it's an extremely useful thing to be able to evaluate patients, but also communicate with patients and educate them about what's going on inside their eyes.
I just love the implementation of science and research into clinic, and I mean, and this is just a perfect example of that. I was thinking as you were talking that how serious people take floaters. I mean, even the name is kind of silly, floaters. They something that maybe a child would wear in a swimming pool. You know what I mean? But hey, it's serious. It's very serious. In fact, as you noted, vitreous floaters have the potential to compromise visual function, for example, contrast sensitivity and patient quality of life. Don't those meet the criteria for disease? I mean, can you comment on that real quickly?
I would agree with your statement, and I have come to that conclusion as well, that the term floaters doesn't really capture the patient experience because it does sound banal. It does sound insignificant. And so I have coined the term vision degrading myodysopsia to be a diagnostic term to refer to patients who have clinically significant floaters. Mind you, floaters are not objects. And I know that the literature and everybody in the world speaks about, I have floaters in my eye. I reserve the term floaters to refer to the visual phenomenon that's created by opacities within the vitreous body in the center of the eye. And when those opacities impact vision, if they're large enough and numerous enough, and they impact vision sufficiently, I employ the term vision degrading myodysopsia. Now, I'll be the first to admit that that's a really awkward term, and it hasn't been very popular in the medical community. It's catching on, but still, it doesn't roll off your tongue. But in a way, that was purposeful because vision degrading myodysopsia really sounds like a disease. And I think that it begins the paradigm shift that needs to occur if we're going to think about this differently than we have up until now. So I employ that term, and I recognize how floaters as a term is used throughout the world, but I'm hopeful that the paradigm shift that we've begun with the term vision degrading myodysopsia and by introducing the use of quantitative ultrasonography and measuring contrast sensitivity, things that everybody can do, they just don't, that implementing those in the evaluation of patients will raise this to a level of consciousness in the medical community that we begin to use our tremendous creative forces to develop ever better ways to diagnose and manage this disease.
Agreed. I mean, certainly the term vision degrading myodysopsia, it may not roll off the tongue, but it's something that it makes you stand up and take notice. It sounds more serious, certainly. So, yeah, I mean, I appreciate that effort and, am happy to help promote that for sure. Um, so, changing the topic a little bit here, are there any lifestyle factors or health habits that contribute to the development of vitreous floaters?
I'm not aware of any data that addresses lifestyle habits. Other diseases of the eye have been linked to systemic conditions like diabetes, um, smoking, high blood pressure, etc. That isn't the case in vitreous. We do know that diabetes causes increased levels of sugar in the vitreous body, and that does result in cross-linking of the collagen within the vitreous body, just like it does in collagen throughout the body in patients with diabetes. So that is a subset of individuals. People who I see very often complaining of problems related to the vitreous and retina have myopia, nearsightedness. And I think that that is a significant risk factor to the development of vitreous pathology and ultimately complaining of the visual phenomenon of floaters that are induced by the changes within the vitreous body. We've studied this and found a high correlation between the degree of axial myopia, meaning how long the eye is, and the degree of echo density within the vitreous body. So the more myopic you are because your eye is longer, the greater the density of the vitreous as quantified by ultrasonography. And that translates into more degradation in contrast sensitivity and more unhappiness. So myopia is, in response to your question, the leading risk factor to the development of vision degrading myodysopsia. It's not the number one cause of floaters. That would be a posterior vitreous detachment, which afflicts older individuals. The average age of a posterior vitreous detachment is 61 for men and 59 for women. But there's a distribution to both sides of those numbers. And it's well known that having myopia lowers that average age of posterior vitreous detachment by 0.91 years for each diopter of myopia. So there is an interplay between those. And in fact, the most unhappy people who I have met complaining of floaters are people who have both myopic vitreopathy and a posterior vitreous detachment. And we've done studies to show that those individuals, in comparison to the other subgroups, have the most dense vitreous and the most degradation in contrast sensitivity, which is why they're the most unhappy.
Gotcha, gotcha. Yeah, certainly. You mentioned diabetes and sugar, and certainly given my role here at MacuHealth and my research background in nutritional effects on, vision and cognition, I wonder if, you see a role, if any, for nutrition in, potentially, modifying or, potentially, preventing, delaying the onset of floaters. I do know that in other situations in the body that oxidation, inflammation can play a role in the glycation of collagen, and the fact that the vitreous does contain largely water, but it does have several macronutrients, certainly polyphenols, bioflavonoids, these kinds of things that exist there. I wonder if you see a role for nutrition in any of this.
Well, I think that in medicine in general, we are increasingly aware of the fact that both health and disease result from an interplay between your genetics and your environment. And one of the leading components of the environment is what you eat and what you consume. And so, nutrition as a leading component of the environment that we live in has a very important role in the interplay with genetics. And that's why you see some people who have a certain genetic profile can get away with smoking, can get away with obesity, can get away with high blood pressure, and it doesn't damage them as much as other people. I mean, we know lots of cases of lung cancer who've never smoked cigarettes in their lives. So it's a complex issue. I believe that nutrition, as a leading component of our environment, does have a role in the interplay with our genetics. And it's a very complex situation that requires a lot more information before we understand it clearly and before we can do something in that domain. But I do believe it plays an important role. Yes.
Yes, it sounds like there's room for research in that area for sure, and maybe we can help ultimately. Well, yeah, this has been great. Let's wrap it up. Do you have any concluding remarks? Anything you want to sort of pass along to doctors or patients that may be listening?
Well, before concluding remarks, I would like to spend a few minutes talking about therapy because we've spent a great deal of time so far in this session talking about the diagnosis and the management and how do we better understand what's going on. That has translated directly into therapeutic intervention. And in specific, again, about 13, 14 years ago, when I started to gain a better understanding of the plight of people who suffer from floaters, I opened my mind and I opened my heart to doing something about it. And at that time, what I did primarily was vitrectomy. And in looking at the way we did vitrectomy, I realized that the advent of small gauge vitrectomy instruments that simplified the vitrectomy operation paved the way for discussing the option of doing a vitrectomy in patients who have vision degrading myodysopsia. But I modified the approach. I had a choice. I could have devised and designed a vitrectomy procedure that was effective in the hopes that it would be safe, but rather I designed a procedure that was safe in the hopes that it would be effective. And I call that limited vitrectomy. I now call that limited refractive vitrectomy. And the reason is that we're actually a variant of refractive surgery intended to improve patients' contrast sensitivity. And therefore, the performance of a vitrectomy is a type of refractive surgery that should be very helpful to lots and lots of patients. Just as an aside, patients who have degradation in contrast sensitivity because of multifocal intraocular lenses are a pretty frustrating experience for patients and doctors alike. But we showed and have published that those patients would benefit from a limited vitrectomy to improve their contrast sensitivity. It doesn't come back to normal because they still have the impact of the multifocal intraocular lens, but it does improve enough so that they're happier. And let's face it, at the end of the day, this is all about happiness. So we've been very fortunate over the years to perform hundreds of limited vitrectomies defined by leaving some vitreous behind the lens to mitigate against cataracts, but also not inducing a surgical posterior vitreous detachment. That is the essence of a limited vitrectomy. And it's been very safe, which was our initial objective, but it's also been very effective. And we've published this a number of times, so I won't belabor the audience with all of the specifics. They are available in the peer-reviewed literature. But there are other ways to manage patients with vision-degrading myodysopsia or patients who have floaters that don't qualify for the diagnosis of vision-degrading myodysopsia. These days, we are investigating with a scientific protocol using quantitative objective outcome measures, the use of YAG laser vitreolysis to treat patients who have opacities within their vitreous body that are causing the visual phenomenon of floaters. I predict that the YAG laser technology will improve with better localization, but it can also be replaced with better lasers, such as picosecond or femtosecond lasers. There's also a project at the University of Ghent that uses nanoparticles that are built in such a way that they'll adhere to the opacities within the vitreous body that are creating the visual phenomenon of floaters. And then with a low level laser, it's been estimated that the energy levels of that laser will be 1,000 times less than what is currently used during YAG laser vitreolysis, and that the low-level laser will be able to ablate the opacities and uh, reduce the symptoms of floaters and treat vision-degrading myodysopsia. The studies so far have been done in vitro, and we've done them in an animal model in the rabbit, but there's a lot of work that needs to be done developing that technology and testing it in humans to be sure that it's safe and to be sure that it's effective. So these are less invasive ways to approach the problem of floaters and vision degrading myodysopsia. And I think nutrition will play a role in the armamentarium of approaches to handle this disease. I certainly think that nutrition will play a role in preventing vision degrading myodysopsia. It remains to be seen whether established pathology can be reversed with nutrition, but it's certainly theoretically possible.
Outstanding. I mean, that's fascinating, and hearing about the limited vitrectomy, that's getting right back to a do no harm approach, and it's encouraging to hear that, and I'm so glad that's been successful. Well, this has been a real learning experience for me, and I'm sure everybody who's listening. Thanks again for joining us today, Dr. Sabag. Yeah, I really appreciate your time. It's been a privilege.
Thank you very much. I appreciate the opportunity.
Yeah, you bet.